the ultimate goal of weaning is extubation. And this is virtually always preceded by a spontaneous breathing trial. So the question is, how do we know when is the right time to do a spontaneous breathing trial? We can decide to undertake it based on clinical gestalt or heuristics, or we can screen for weanability using weaning predictor tests. Kahneman and Tversky are two psychologists who received the Nobel Prize for their research on how people form judgments in the midst of uncertainty. Much of their research focused on heuristics, and they found that heuristics, or rules of thumb, commonly lead to systematic and predictable errors. And this is borne out by the first two randomized trials on weaning techniques, where 60 to 80% of patients ventilated for a week or more had the ventilator successfully removed on the first day they were evaluated for weaning. Many of these patients probably could have been had the ventilator removed a day or several days sooner, and so this emphasizes that relying on gestalt or heuristics alone leads to delays in the initiation of weaning. The timing of weaning, or its prediction, is built on four foundational pillars. The first pillar is to avoid gestalt and heuristics and to instead use a specific screening test. The goal of a screening test is to pick up cases of a condition at the earliest possible time. Screening hinges on minimizing the number of false negative results and maximizing the number of true positive results. And sensitivity captures exactly these constituents, because sensitivity is the true positives divided by the true positives plus the false negatives. The average sensitivity in 27 studies of F over VT is 0.89, and 85% report sensitivities above 0.98. The sensitivity for a spontaneous breathing trial is unknown, and ethics makes it impossible to find out. You would need to extubate patients who had already failed a T-piece trial in order to find out the sensitivity. The goal of a confirmatory test is to confirm a condition for which there is already a strong suspicion. Confirming hinges on minimizing the false positive results and maximizing the true negative results. And specificity captures exactly these constituents, since the specificity is true negative results divided by the true negative results plus the false positives. An EBM task force conducted a meta-analysis on weaning predictor tests and concluded that all predictors were unreliable and that it was best to skip predictor screening tests and start with a spontaneous breathing trial, even though the sensitivity of that test is unknown. The task force focused on likelihood ratio, which is not precisely suited to evaluating a screening test. Likelihood ratio includes components that are vital for screening, but it also includes components that are not directly focused on screening. And the latter cloud the contribution of the vital components. So the first scientific foundation on weaning prediction is to focus on screening, and that means sensitivity. And do not mix screening and confirmation. And also it's important to avoid a monolithic orientation as with likelihood ratio. The second foundational element is shown in the following example. Here's an excellent diagnostic test. False positive rate is 5%, false negative rate 0%, and the incidence of disease is 1 in 1,000. A randomly selected person undergoes testing. The test comes back positive. What's the chance that the person has the disease? When this question was put to physicians at Harvard, most answered 95%, whereas the correct answer is less than 2%. Those who answered 95% commit the base rate fallacy. They're ignoring the incidence of disease. This is analogous to when you see zebras, you hear hoofbeats. So whenever you hear hoofbeats, then you conclude there must be zebras. In weaning prediction, to avoid the base rate fallacy, you must take the pretest probability of weaning success into account. That is your clinical gestalt. In his textbook on medical decision analysis, Sachs, the editor of the Annals, states, perhaps the most important idea in this book is the following: the interpretation of test results depends on the pretest probability of disease. Here's a relationship for a very good diagnostic test. Sensitivity and specificity are both 0.9. As the pretest probability increases, so does the post-test probability. So if the pretest probability is 0.4, and you get back a positive result, you reach a post-test probability of about 0.9, an increase of 0.5 units. If the pretest probability is 0.8, a positive result has a much smaller effect, despite identical sensitivity and specificity. This is a huge problem in weaning research because more than half the studies of predictors have been conducted in populations where the weaning success rate was 75% or higher. Weaning predictors have little chance to substantially increase the post-test probability in this situation. And this concern was completely ignored by the EBM task force. So the second scientific foundation of weaning prediction is to avoid the base rate fallacy, to recognize that pretest probability is pivotal, and for a predictor to help, it must be done when the pretest probability of disease is low, like 20 to 40%. The third scientific foundation is to recognize that weaning prediction basically means the application of probability theory. There is a rich science in probability theory developed over centuries by the people shown here on this slide. So when a task force ignores these foundations, errors are inevitable. In particular, we need to distinguish between different types of probability. Ordinary or unconditional probability involves the occurrence of a single event. For example, what's the probability of the event of getting a 2 on a roll of the dice? The outcome of each roll is independent of all other rolls. The outcome is not influenced by previous rolls, and it's not conditioned by previous rolls, nor does it influence future rolls. In contrast, conditional probability involves the occurrence of 2 events. The occurrence of the second event depends, or is conditional on, the previous occurrence of the first event. So, for example, what is the probability of the event, the presence of a particular disease, given a positive diagnostic test? Bayes' theorem consists of an equation that uses new information to update old information, the pretest probability, or the initial clinical gestalt. The updated result is termed the conditional probability, or the post-test probability, and sometimes expressed as the positive or negative predictive value. Specifically for weaning, Bayes' theorem estimates how much the uncertainty of weaning outcome changes from before measurement of a weaning predictor test, the pretest probability, to the point after obtaining the new information. That is the conditional probability. So the conditional probability of weaning failure is higher if the respiratory rate is 35 than if it is 20. All diagnostic testing operates through Bayes' theorem, based on conditional probability, not on unconditional probability. So the first caution is that when evaluating a weaning predictor, you must apply principles of conditional probability, not conditions of unconditional probability, like looking at the roll of a dice. The second caution is that when evaluating a weaning predictor, you must also ensure conditional independence. Now, conditional independence is a different concept from conditional probability and also from unconditional probability, as I'm about to explain. Two conditions are considered conditionally independent when knowledge that one event has occurred tells you nothing about whether or not a second event is likely to occur. The two events, patient has appendicitis and patient has a broken toe, are conditionally independent. Conditioning of one event doesn't change the probability of the other event. The two conditions or two events, patient has appendicitis and patient has abdominal pain, are not conditionally independent. The conditional probability of abdominal pain, given the presence of appendicitis, is much higher than the non-conditional probability of abdominal pain. In other words, the likelihood of abdominal pain is much higher in people with appendicitis than in the overall general population. Diagnostic testing in weaning commences when a clinician first feels that a patient's respiratory failure has resolved. The usual approach is to perform a weaning predictor test, followed by a weaning trial consisting of a T-tube trial or pressure support. That is, we do sequential diagnostic testing. So if, for example, the F/VT came back at 160, many physicians will not proceed to a weaning trial because of the high likelihood of distress and the potential for complications. Reluctance to undertake a spontaneous breathing trial in a patient who has a negative F/VT result demonstrates that clinicians do not view the two tests, the F/VT and the weaning trial, as conditionally independent of one another. When investigators consider tests done in sequence as two independent tests, they violate conditional independence. Investigators, like the EBM task force, who violate conditional probability and conditional independence, are in effect discrediting the foundational principles of probability theory developed by brilliant minds over several centuries. So the third scientific foundation of weaning prediction is, do not treat conditional probability as if it were unconditional probability. Do not violate conditional independence when assessing sequential tests. The fourth scientific foundation is to avoid spectrum bias and test referral bias. Weaning involves several diagnostic tests done in sequence: measurement of predictors, performance of a weaning trial, and then a trial of extubation. The use of more than one diagnostic test in sequence poses a very high risk for the occurrence of spectrum bias and test referral bias. Spectrum bias occurs when a new study population contains fewer or more sick patients than the population in which the diagnostic test was originally developed. The mechanism of spectrum bias is illustrated by the following hypothetical study, in which investigators wish to determine if F over Vt is reliable in predicting extubation outcome. They study 100 patients and they measure F over Vt. The average result is 111. Because they don't know if F over Vt is reliable or not, all patients proceed to a T-tube trial, and if they pass that trial, they continue to a trial of extubation. The investigators report that F over Vt is reliable, and another group decide to reevaluate its usefulness. They also study 100 patients, and the average F over Vt is again 111. 70 patients have positive F over Vt results, and 30 have negative results. The 70 patients with the positive results proceed to a T-tube trial. Because the initial study revealed that negative F over Vt results were reliable in predicting weaning failure, clinicians refused to undertake a T-tube trial in the 30 patients with the negative F over Vt results. These are excluded from the new study. The exclusion of patients with negative F over Vt results in a change in the spectrum of disease. The initial group of 100 patients with an F over Vt of 111 was sicker than the new group of 70 patients with an average F over Vt of 90. And spectrum bias also alters the sensitivity and the specificity of the test. And this is shown on the next example. Because a second bias that results is test referral bias. And this occurs when the results of a test under evaluation are used to select patients for a reference standard test, such as the use of a weaning predictor test to select patients for the reference standard test passing a weaning trial that leads to extubation. To explain test referral bias, I need to go a step deeper, and we need to examine another hypothetical study, a study to develop a new weaning predictor test. The initial study population consists of 50 success and 50 failure patients. Of the 50 success patients, 45 have positive test results, so the true positive rate, or the sensitivity, is 0.9. Of the 50 failure patients, 35 have negative test results, so the false positive rate is 0.3, or the specificity is 0.7. In a subsequent evaluation of this index, clinicians decide not to do a T-tube trial in 80% of patients with negative test results. This changes both the sensitivity and the specificity of the test. In the success arm, the 80% decrease in the negative test results causes a decrease in the false negatives. And since the true positives don't change, the true positive rate increases to 0.98. In the failure arm, the 80% decrease in the negative tests causes a decrease in the true negatives. And since the false positives don't change, the false positive rate increases to 0.68. The exclusion of 80% of negative test results also affects the disease spectrum, as the pretest probability of success increases from 0.5 to 0.62. The task force wrote that the importance of selection bias in this literature was difficult to assess because the reporting of patient selection in individual studies was not detailed. For the vast majority of studies, selection bias was not evident. Contrary to what the task force say, the vast majority of authors did show evidence of selection bias. These two groups of investigators required patients to have a frequency of less than 35 and a tidal volume of greater than 5 ml per kilogram. So for an average 70 kilogram patient, these criteria result in an F over VT of less than 100. So by design, no patient with an F over VT of 100 would undergo a weaning trial. Thus, they exclude the weaning failure patients in whom F over VT has the highest likelihood of being accurate. These investigators required an F over VT of less than 125 for entry. Again, they exclude the weaning failure patients in whom F over VT has the highest likelihood of being accurate. So the fourth scientific foundation of weaning prediction is do not commit spectrum bias, where investigators recruit less sick patients in a follow-up study, and also do not commit test referral bias, where investigators exclude the very patients in which a predictor has the greatest likelihood of being accurate. Both spectrum bias and test referral bias were ignored by the EBM task force. So I've listed the four scientific foundations of weaning prediction. But there is a deeper issue in science, one which relates to the very basis of scientific methodology. The most important method in science is argument and counter-argument. And this is the most important part of the entire scientific method. In this article, we discuss the various problems in the task force's meta-analysis, and these were further articulated in a letter to the editor. The editor, Dr. Perillo, points out that multiple attempts have been made to obtain a response, but they've refused to give a response. I regret that the group has chosen not to respond and participate in this scientific dialogue. More than 20 years ago, Engl asked, is weaning an art or a science? Weaning prediction cannot even begin to resemble a science when investigators disregard the scientific principles of probability theory. Without solid foundations, we cannot expect our clinical practice to constitute an art, let alone a science. When a task force makes recommendations that contradict scientific principles, they base clinical practice on a very flimsy foundation. These recommendations do fully satisfy all of the criteria of EBM, but none of those of Bayes, Bernoulli, and Gauss.